Okay, another important conventional antipsychotic, which is haloperidol. The trade name of Haloperidol, it's high potency, and it can be used as depot injections. Let's talk about that. So, haloperidol, dopamine receptor antagonist, conventional antipsychotic, neuroleptic, but it is from the butyrophenone kind, butyrphenone. And of course, it's D2 antagonist. Okay, commonly prescribed for manifestations of psychotic disorders like oral immediate release and injection. You can use it in these forms. Tics and vocal utterance in Tourette syndrome, oral immediate release injection. Second line treatment of severe behavior problems in children of combative, explosive hyperexcitability. We can use oral and immediate release injections for these. Second line short-term treatment for hyperactive children. We can use also oral or immediate release injection. And treatment of schizophrenic patients who require prolonged parenteral antipsychotic therapy. We use depot intramuscular decanoate for these. It is used off-label for bipolar disorder, behavioral disturbance in dementias, and in delirium with lorazepam. So, how the drug works, as we said about other conventional antipsychotics, by blocking dopamine D2 receptors. So, okay, by blocking D2 receptors, it can in the mesolimbic pathway, it can alleviate psychotic symptoms and possibly explosive and hyperactive behaviors. And by blocking dopamine D2 receptors in the nigrostriatal pathway, this can improve the tics and other symptoms in Tourette syndrome. How long until it works? Psychotic symptoms can improve within 1 week, but it can take several weeks for full effect on behavior. If it works, most often reduces positive symptoms in schizophrenia but does not eliminate them. Most schizophrenic patients do not have a total remission of symptoms, but rather reduction of symptoms by about a third. Continue treatment in schizophrenia until reaching a plateau of improvement. After reaching a satisfactory plateau, continue treatment for at least a year after first episode of psychosis in schizophrenia. For second and subsequent episodes of psychosis in schizophrenia, treatment may need to be indefinite. Reduces symptoms of acute psychotic mania but not proven as a mood stabilizer or as an effective maintenance treatment in bipolar disorder. So after reducing acute psychotic symptoms in mania, switch to a mood stabilizer and or an atypical antipsychotic for mood stabilization and maintenance. What if it does not work? You consider trying one of the first-line atypical antipsychotics like risperidone, olanzapine, quetiapine, ziprasidone, aripiprazole, paliperidone, asenapine, iloperidone, lorazepam, and amisulpride, or amisulpride, of course. Consider trying another conventional antipsychotic, and if 2 or more antipsychotic monotherapies do not work, you consider clozapine. What are the best augmenting combos for partial response or treatment resistance? Augmentation of conventional antipsychotics has not been systemically studied. Addition of a mood stabilizing anticonvulsant such as valproate, carbamazepine, or lamotrigine may be helpful in both schizophrenia and bipolar mania. Augmentation with lithium in bipolar mania may be helpful also. Addition of benzodiazepine, especially short-term for agitation. About tests, since conventional antipsychotics are frequently associated with weight gain, before starting treatment, weigh all patients and determine if the patient is already overweight or obese. And before giving a drug that can cause weight gain to an overweight or obese patient, consider determining whether the patient already has prediabetes, fasting plasma glucose, diabetes, or dyslipidemia, LDL cholesterol and triglyceride, okay, all of these things, okay, and treat or refer such patients for treatment, including nutrition and weight management, physical activity counseling, smoking cessation, and medical management. Monitor weight and body mass index during treatment. Consider monitoring fasting triglycerides monthly for several months in patients at high risk for metabolic complications, and when initiating or switching antipsychotics. While giving a drug to a patient who has gained more than 5% of initial weight, you consider evaluating for the presence of prediabetes, diabetes, or dyslipidemia, or consider switching to a different antipsychotics. You should check blood pressure in the elderly before starting and for the first few weeks of treatment, monitoring elevated prolactin levels for dubious clinical benefit. Patients with low white blood cell count or history of drug-induced leukopenia or neutropenia should have complete blood count monitored frequently during the first few months, and haloperidol should be discontinued at the first sign of decline of WBC in the absence of other causative factors. So let's talk about side effects. How drug causes side effects? By blocking dopamine 2 receptors in the striatum, it can cause motor side effects. By blocking dopamine 2 receptors in the pituitary, it can cause elevation in prolactin. And by blocking dopamine 2 receptors excessively in the mesolimbic and the mesocortical dopamine pathways, especially at high doses, it can cause worsening of negative and cognitive symptoms. So that's called neuroleptic induced deficit syndrome. By blocking alpha-1 adrenergic receptor, it can cause dizziness, sedation, and hypotension. Mechanism of weight gain and any possible increased incidence of diabetes or dyslipidemia with conventional antipsychotics is unknown. We have notable side effects like neuroleptic induced deficit syndrome, akathisia, extrapyramidal symptoms, Parkinsonism, tardive dyskinesia, and tardive dystonia, galactorrhea, amenorrhea also, dizziness, sedation, dry mouth, constipation, urinary retention, blurred vision, decreased sweating, hypotension, tachycardia, hypertension, and weight gain. Life-threatening or dangerous side effects like rarely neuroleptic malignant syndrome, rare seizures, rare jaundice, agranulocytosis, leukopenia, increased risk of death, and cerebrovascular events in elderly patients with dementia-related psychosis. It's not usually causing weight gain, occurs in significant minority, and it's not unusual to cause sedation also. Sedation is usually transient. What to do about side effects? You wait, and for motor symptoms you can add an anticholinergic agent, reduce the dose. For sedation you can give at night. You switch for an atypical antipsychotic to an atypical antipsychotic. You can use, weight loss exercise programs and medical management for high body mass index, diabetes, and dyslipidemia. Best augmenting agents for side effects, benztropine or trihexyphenideine for motor side effects. Sometimes amantadine can be helpful for motor side effects. Benzodiazepines may be helpful for akathisia, and many side effects cannot be improved with an augmenting agent actually. So what about dosing? Usual dosage range from 1 to 40 mg per day orally. Immediate release injection 2 to 5 mg each dose. The decanute injection is 10 to 20 times the previous daily dose of oral antipsychotic. We'll talk about that. So the forms are something like tablets 2.5, 1, 2, 5, 10, and 20. We have concentrate 2 mg per milliliter, solution of 1 mg per milliliter, injection 5 mg per milliliter. This is for immediate release. And for the canute injection, we have 50 mg per milliliter and 100 mg per milliliter. How to dose? Orally, you can initiate with 1 to 15 mg per day, can give once daily or in divided doses at the beginning of treatment during rapid dose escalation. Increase as needed, can be dosed up to 100 mg per day. Safety not established for doses over 100 mg per day. Immediate release injection, the initial dose would be 2 to 5 mg. Subsequent doses may be given as often as every hour. Patient should be switched to oral administration as soon as possible. Some dosing tips for oral. Haloperidol is frequently dosed too high. Some studies suggest that patients who respond well to low doses of haloperidol, approximately 2 mg per day, may have efficacy similar to atypical antipsychotics for both positive and negative symptoms of schizophrenia. Higher doses may actually induce or worsen negative symptoms of schizophrenia. Low doses, however, may not have beneficial actions for treatment-resistant cases or violence. One of the only antipsychotics with a depot formulation lasting for up to a month. This is haloperidol. Treatment should be suspended if absolute neutrophil count falls below 1000 millimeter cube. Okay. Overdose can facilitate fatalities have been reported. Okay, because of extrapyramidal symptoms, hypotension, sedation, respiratory depression, and shock-like state. For long-term use, often used for long-term maintenance, some side effects may be irreversible, like tardive dyskinesia, but no habit forming. How to stop? You can titrate oral formulation over 6 to 8 hours, especially when simultaneously beginning a new antipsychotic while switching. This is cross titration. But rapid oral discontinuation may lead to rebound psychosis and worsening of symptoms. In antiparkinsonian agents as being used, they should be continued for a few weeks after haloperidol is discontinued. Pharmacokinetics. The cannulate half-life approximately 3 weeks. Oral half-life approximately 12 to 38 hours. About drug interactions, haloperidol may decrease the effects of levodopa, dopamine agonist, may increase the effects of antihypertensive drugs except for guanethidine, those whose antihypertensive actions haloperidol may antagonize. Additive effects may occur if used with CNS depressants. Those of other agents should be reduced. Some pressor agents like epinephrine may interact with haloperidol to lower blood pressure. So haloperidol and anticholinergic agents together may increase intraocular pressure, of course, reduces effects of anticoagulants. Plasma levels of haloperidol may be lowered by rifampin. Some patients taking haloperidol and lithium have developed an encephalopathic syndrome similar to neuroleptic malignant syndrome. Haloperidol may enhance effects of antihypertensive. Other warnings and precautions. If signs of neuroleptic malignant syndrome develop, treatment should be immediately discontinued. Use with caution in patients with respiratory disorders. Avoid extreme heat exposure. If haloperidol is used to treat mania, patients may experience a rapid switch to depression. Okay, patients with thyrotoxicosis may experience neurotoxicity. Use only with caution, if at all, in Parkinson's disease or lower body dementia. Higher doses and IV administration may be associated with increased risk of QT prolongation and torsades de pointes. Use particular caution if patients have QT prolongation condition, underlying cardiac abnormalities, hypothyroidism, familial long QT syndrome, or is taking a drug known to prolong QT interval. Do not use if the patient is in comatose state or has CNS depression, and if patient has Parkinson's disease. There is a proven allergy, and do not use if there is a proven allergy to haloperidol. Okay, special population. Use with caution in renal and hepatic impairment. For cardiac impairment, use with caution because of risk of orthostatic hypertension and the possible increased risk for QT prolongation or torsades de pointes at higher doses or IV administration. For elderly, lower doses should be used and patients should be monitored closely. Elderly patients may be more susceptible to respiratory side effects and hypotension. Okay, although conventional antipsychotics are commonly used for behavioral disturbances in dementia, no agent has been approved for treatment of elderly patients with dementia-related psychosis. Elderly patients with dementia-related psychosis treated with antipsychotics are at increased risk of death compared to placebo. And also have an increased risk of cerebrovascular events. Children and adolescents. Safety and efficacy have not been established, not intended to use under the age of 3. For orally, the initial dose would be 0.5 milligram per day, and target dose would be 0.05 to 0.15 milligram per kg per day for psychotic disorders, and 0.05 to 0.075 milligram per kg per day for non-psychotic disorders. Generally considered second line after atypical antipsychotics, so don't use that as a first line. For pregnancy, controlled studies have not been conducted in pregnant women. There is a risk of abnormal muscle movement and withdrawal symptoms in newborns whose mothers took an antipsychotic during the 3rd trimester. Symptoms may include agitation, abnormally increased or decreased muscle tone, tremor, sleepiness, severe difficulty breathing and difficulty feeding, reports of extrapyramidal symptoms, jaundice, hyperreflexia in infants whose mothers took a conventional antipsychotic during pregnancy, reports of limb deformity in infants whose mothers took haloperidol during pregnancy. This is for haloperidol. Haloperidol should generally not be used during the 1st trimester. Haloperidol should only be used during pregnancy if clearly needed, and psychotic symptoms may be worsened during pregnancy, and some form of treatment may be necessary. So atypical antipsychotics may be preferable to conventional antipsychotics or anticonvulsant mood stabilizers if treatment is required during pregnancy. For breastfeeding, some drug is found in mother's breast milk, so recommended either to discontinue drug or bottle feed. About the art of psychopharmacology, we have potential advantages for haloperidol. We have intramuscular formulation for emergency use. We have 4-week depot formulation for non-compliance, and low dose responders may have comparable positive and negative symptom efficacy to atypical antipsychotics, low cost and effective treatment. But we have some potential disadvantages, like patients with tardive dyskinesia or who wish to avoid tardive dyskinesia and extrapyramidal symptoms, vulnerable populations such as children or elderly, and patients with notable cognitive or mood symptoms. Primary targets of symptoms are positive symptoms of psychosis, of course with violent or aggressive behavior. Some pills. Prior to the introduction of atypical antipsychotics, haloperidol was one of the most preferred antipsychotics. Haloperidol may still be useful antipsychotic, especially at low doses for those patients who require management with a conventional antipsychotic or who cannot afford an atypical antipsychotic. Low doses may not induce negative symptoms, but high doses may. Not clearly effective for improving cognitive or affective symptoms of schizophrenia. May be effective for bipolar maintenance, but there may be more tardive dyskinesia when affective disorder are treated with conventional antipsychotic long term. Less sedating than many other conventional antipsychotics, especially low potency phenothiazines. Haloperidol is often used to treat delirium, generally in combination with lorazepam, with the haloperidol dose 2 times the lorazepam dose. Haloperidol's long-acting intramuscular formulation lasts up to 4 weeks, whereas some other long-acting intramuscular antipsychotics may last only up to 2 weeks. Decanuate administration is intended for patients with chronic schizophrenia who have been stabilized on oral antipsychotic medication. Patients have very similar antipsychotic responses to any conventional antipsychotic, which is different from atypical antipsychotics, where antipsychotic responses of individual patients can occasionally vary greatly from one atypical to another. Patients receiving atypical antipsychotics may occasionally require a top-up of a conventional antipsychotic such as haloperidol to control aggression or violence. Patients with inadequate responses to atypical antipsychotics may benefit from trial of augmentation with a conventional antipsychotic such as haloperidol, or from switching to a conventional antipsychotic such as haloperidol. Okay. However, long-term polypharmacy with a combination of a conventional antipsychotic such as haloperidol with an atypical antipsychotic may combine their side effects without clearly augmenting the efficacy of either. So for treatment-resistant patients, especially those with impulsivity, aggression, violence, and self-harm, long-term polypharmacy with 2 atypical antipsychotics or with 1 atypical antipsychotic and 1 conventional antipsychotic may be useful or even necessary while closely monitoring. In such cases, it may be beneficial to combine 1 depot antipsychotic with 1 oral antipsychotic. So let's talk about haloperidol decanuate. So the vehicle is sesamoyl oil. The Tmax is 3 to 9 days. Half-life of multiple doses 21 days. Time to reach steady state is 4 weeks with loading. Able to be loaded, yes. Dosing schedule is 4 weeks. Injection site intramuscular. Needle gauge is 21. Dosage forms 50 and 100, and the injection volume would be 50 or 100 milligram per milliliter, not to exceed 3 milligrams. So the usual dosage range is 10 to 20 times the previous oral dose. How to dose? Conversion from oral loading with 20 times oral daily dose. 20 times or the oral daily dose for the first month, okay? Divided into 2 bi-weekly injections. Weekly loading is an alternative option, may require oral coverage for the first week. So if a patient is taking, for example, 5 milligrams daily oral, we give the loading of 100 for the first month, divided into 2 bi-weekly. Okay, we give it 50-50 every 2 weeks, or even 25-25 for every week. I understand it like this. Some dosing tips. With long-acting injections, the absorption rate constant is slower than the elimination rate constant, thus resulting in flip-flop kinetics. Time to steady state is a function of absorption rate, while concentration is at steady state is a function of elimination rate. The rate of limiting step for plasma drug levels for LAIs is not drug metabolism, but rather slow absorption from the injection site. In general, 5 half-lives of any medication are needed to achieve 97% of steady-state levels. The long half-lives of depot antipsychotics mean that one must either adequately load the dose if possible or provide oral supplementation. Failure to adequately load the dose leads either to prolonged cross-titration from oral antipsychotic or to subtherapeutic antipsychotic plasma levels for weeks or months in patients who are not receiving or adhering to oral supplementation. Because plasma antipsychotic levels increase gradually over time, those requirements may ultimately decrease from initial. Obtaining periodic plasma levels can be beneficial to prevent unnecessary plasma level creep. The time to get a blood level for patient receiving LAI is the morning of the day they will receive their next injection. Advantages are reliable conversion formula from oral dosing, established loading regimen. Disadvantages like higher incidence of local site reactions due to sesamoyl oil vehicle, even with loading, may require oral coverage for at least a week. Okay. Response threshold is generally 3 to 5 nanogram per milliliter. Plasma level greater than 20 nanogram per milliliter are generally not well tolerated. So single injection volumes greater than 300 or 3 milliliter are not tolerated. So patients who require higher doses typically receive the monthly dose as split injections every 2 weeks. So we need this, 20 nanogram per milliliter. This is this is 3 to 5 nano. No, this is the therapeutic, let's say, threshold, not more than 20 nanogram per milliliter. Okay, a loading strategy advocated by some is to give 300 milligram LAI every 1 to 2 weeks for 2 doses, and then measure plasma drug concentration just prior to a third loading dose to see if a third dose is necessary. Okay, so here we have this switching from oral antipsychotic to haloperidol decannuate. Here we have the haloperidol decannuate kinetics, plasma haloperidol concentration. This is okay, this is it, and this is the time. Here we have, you know, the concentration is getting up and down. The therapeutic, as we said, this is the efficacy threshold is much lower. It's from 2 to 3, and the tolerability threshold is right there. So we have a lot of space to play within. So discontinuation of oral antipsychotic can begin immediately if adequate loading is pursued. However, oral coverage may still be necessary for the first week. How to discontinue oral formulation? Down titration is not required for amisulpride, aripiprazole, brexpiprazole, cariprazine, or paliperidone ER. 1 week down titration is required for iliperidone, lorazepam, risperidone, and ziprazidones. 3 to 4 weeks for penes like asenapine, olanzapine, and quetiapine, but 4 weeks for clozapine especially. For patients taking benzodiazepine or anticholinergic medication, this can be continued during cross titration to help alleviate side effects such as insomnia, agitation, and or psychosis. Once the patient is stable on LAI, these can be tapered one at a time as appropriate. Okay, that's it about haloperidol. These are some suggested readings about it. So that's it.